Hello, my name is Shailisa. I am at Herzing University and NU675 discussion patient one crisis intervention um, of a 45-year-old male with major depression. Okay, so let's do a quick overview of what's going on with this patient. This patient has major depression. He was diagnosed in his 20s and it had been managed okay with the 20 milligrams of Celexa. Um, He also had a past history of pornography addiction, and it caused some strain in his marriage. But they have, according to him, reportedly have been doing good over the last 5 years. Um, Recently, he discovered that his wife had been unfaithful, had been cheating for the last 2 years, and he came home and there was a note saying that she left him, she took their two children, and ever since he has been distraught. Since this incident, he reports severe emotional distress, daily alcohol use, and increasing hopelessness um, during this visit. And then we'll question if he was suicidal. He said yes, he has been since they left. Um, he stated that he had planned to shoot himself and that the only thing that was keeping him from shooting himself was his children. But he also stated that he was starting to lose hope that he would ever see his children again. So he also admits to drinking 6 packs nightly, sorry, and he has been declining work performances, which means his performance has decreased at work. They did give him some time off from work, but since being back, he still has not managed to go back to work because of everything that's been going on, which is a lot. So we would classify this patient as high risk because he has an active plan, he has access to the means, and he basically said that he is going to do it. So right away, I did notice that this patient had a lot of risk factors for suicide. He has a history of depression. His alcohol use has increased. He had a recent loss. May have not been in the form of a death, but he has lost his family. He's isolated at home by himself, and he has access to firearms, which is huge. His protective factors, they're gone. His children, his family, everything. He feels alone. That's pretty major. So those are some pretty high risk factors for suicide. Um, I would want to definitely conduct a structured suicide risk assessment using the safety tools or the Columbia Suicide Severity Rating Scale. Um, the safety framework allows me to assess risk and protective factors and determine the level of intervention needed. In this case, he has active suicidal ideation, a specific plan, access to lethal means, and diminished protective factors. So these are some pretty heavy things and some pretty huge risk factors that indicate really, really, really high risk for suicide. So right away, I'm realizing that I'm not leaving this patient alone. I don't want him to go home. I don't want him to carry out on this plan, have his thoughts on going rampant at home by himself. Um, he has active suicidal ideation. He has a specific plan, lethal means. Like we don't want to leave him at home by himself. Because he reports access to firearms and he expressed hopelessness. Um, I would just want to make sure I ensure his safety. So my next step would be to contact emergency services. I would want him to voluntarily. I would try to explain to him that what's going on with him. I want him to be safe. I don't want anything to happen to him, and using these non-judgmental, empathetic tone, and letting him know that validating his point, basically letting him know that these are some very stressful situations and I can understand why you may feel this way. But my job as your provider, your clinician is to protect you. And that's exactly what I want to do. So hopefully I can get him to voluntarily um, go to a facility. But if not, then the next step would be emergency intervention. Given his high risk, I would explain that hospitalization is necessary, but if transparency doesn't work, then we got to go to emergency situation. So next, I would, if he doesn't want to, of course, in a perfect world, hopefully he would see it, he would want to go. But if not, I would call 911, of course, for any resources in the area, and let them know that we have a situation, that we need this patient to go to a facility to protect him, and initiate involuntary hospitalization for him, and to ensure his immediate safety. Okay, so once the patient has gone inpatient, he's stabilized. I definitely want to work on safety planning post stabilization. So once the patient is stabilized, in inpatient or crisis setting, I will begin to collaborate safety planning. So this includes him knowing his triggers, of course, which would be losing his family, but we want to work on some coping mechanisms. We want to work together to create a written step-by-step plan, that he can follow during moments of crisis. I would do this by first, let's work on identifying the warning signs that a crisis is emerging, such as hopelessness, isolation, and drinking. Noting that, hey, if you're feeling like this, you're drinking more, these are warning signs. Um, Next, we want to work on using some of those internal coping strategies, like journaling, walking, exercising, yoga, any of that stuff will help. Then we want to engage his social support, such as his friends and his therapists, people who can basically distract him and encourage him if before he starts going through emergency situation or crisis situation. So definitely support system. And then we want to provide him with the resources. So professional in crisis resources. Um, the number to his therapist that he can call, number to me, the 988 suicide hotline. All these are really, really good resources that we want him to have. We want to restrict his means to carry out these plans. We can't, of course, restrict everything, like if he has pills, but we want to restrict his firearms, alcohol use. Let's get rid of those things that we can potentially use to end our life. Okay, so once everything has settled down, we maybe want to address his current medication, given that, his increased stress. That could be mean changing, that can mean going up, but we definitely want to kind of adjust that, and give him, or even add, to help with some anxiety. We want to definitely treat his alcohol dependence. That's definitely an issue, and then maybe initiate some CBT if we haven't already done that. Of course, 24 to 48 hours post discharge, we definitely want to follow up, but we want to also follow up on him regularly, and till we know without a doubt that he's stabilized. So maybe weekly, every 2 weeks, and then monthly, and then kind of adjust as needed. I didn't touch on this in the beginning, but this is definitely important. We definitely want to document and record everything, but that would go along with, when if we've had to call emergency crisis situations like 911, we definitely want to document um, everything, and make sure it's very thorough in our notes, of course. And like I said, we would definitely do weekly follow-ups until he's stable. All right, to sum it all up, basically, we want to do a thorough assessment. We want to act immediately. We want to admit if needed and treat the underlying problem. And the goal is to prevent him from carrying out his plan. And here are my resources. Thank you so much.